Good morning. Welcome to Atrial Fibrillation Awareness Day here at St. Luke's Mid-America Heart Institute. I'm Dr. Daniel Steinhaus, a cardiac electrophysiologist here. Very excited to have you with us today. So happy you're joining us. I want to give you a quick rundown of what the day is going to look like. We're going to start with a presentation about atrial fibrillation so you can understand more about it, ways that we treat it, and ways that you may be able to help prevent atrial fibrillation in the long run. Then we're going to talk to a couple of patients who have been at St. Luke's that have had atrial fibrillation. They'll give you their experiences and talk to us a little bit about that as well. Finally, we're going to take you through a tour of our lab so that you would know what things would look like if you came into St. Luke's for an ablation procedure to meet us for that. Finally, I'd like to tell you that if you do have questions that come up during the day, please put them into your chat box and we will send an email following this presentation with some answers to those questions. So today, what I want to start talking about is what is atrial fibrillation and why does it happen? What can I do to reduce the risk of atrial fibrillations or episodes of atrial fibrillation? How do I prevent stroke in AFib? What are my treatment options for AFib? And how can I manage my AFib and live the life I want? Well, let's start first by talking about what is atrial fibrillation. To describe this, it's a lot like the electrical system in your house. Your heart has an electrical system inside of it. And the normal electrical function starts at the top part of the heart where that yellow outline is. That's called the sinus node. And that's a pacemaker that we're all born with. And that pacemaker generally sets the heart rhythm for us, and it allows the electricity to flow through the heart. That pacemaker fires, and then what happens is the electricity then travels down electrical pathways to the bottom part of the heart, and that makes the bottom part of the heart beat, and that's really what you feel as your pulse, is the bottom part of the heart beating. We don't really feel the top part, but that's where the electricity begins. In atrial fibrillation, the problem is you have a funny rhythm in the top chamber of the heart, and that drives the bottom chamber of the heart usually to go quite fast and irregular. So in the top part, what's happening is the rhythm is very irregular and it drives the bottom part to go quickly. So you can see that your pulse is faster and a little bit more erratic when you have atrial fibrillation. You can see here on the right side of the screen, the way that this looks on an EKG to a physician is that in normal rhythm, everything looks very orderly, and in atrial fibrillation, things look very chaotic. So what makes atrial fibrillation start? Well, typically what happens is over in the left atrium, which is this chamber that I'm highlighting here with this flashing oval, you have funny electrical impulses that come from the back side of this part of the heart. So this is a flipped around picture of that left atrium. And you can see here that on the back side of it, there are 4 veins that drain into that left atrium. So those are those 4 things that are coming off there. And so you can see the veins and the atrium there. What happens from those veins is you get little extra electrical bursts that trigger the heart to go into atrial fibrillation. So you're going along just fine in normal heart rhythm, in sinus rhythm. You get a burst from one of these areas from these veins, and that sends electrical impulses into the heart to make it go fast. Once those electrical impulses have fired, that's how you end up in atrial fibrillation. So this is showing a little bit of that where the heart's in normal rhythm. These little extra bursts that you can see on the top screen there show these extra electrical activity that come from that area, and then that transforms the normal rhythm into atrial fibrillation that you see below. So the pulmonary veins are the classic trigger for atrial fibrillation, and that's where most atrial fibrillation comes from. But triggers can come from other areas in the heart. They can come from areas in the right atrium, near the middle part of the atrium. They can come from an area in the top part of the heart called the superior vena cava, and they can come from other areas in the left atrium as well. So what keeps atrial fibrillation going? Well, the triggers started, but once the atrial fibrillation is going, the heart is in a short circuit rhythm, and that short circuit will just keep going until it burns out. Some people, atrial fibrillation will stop after minutes to hours, and that's called paroxysmal atrial fibrillation. For some people, atrial fibrillation does not stop unless we perform an intervention like a cardioversion where we apply a lot of electricity to the heart to get the atrial fibrillation to stop. That's called persistent atrial fibrillation. So let's go back to say, who gets atrial fibrillation and why do people get atrial fibrillation? Well, the main thing I will tell you is that atrial fibrillation is extremely common. About 25% of patients in the United States will get atrial fibrillation at some point in their lives. It is extremely prevalent across the entire world, and it's a problem that tends to come as people get older. So as the population in the United States is aging, we are going to see more atrial fibrillation. This is a graph showing that as patients get older, we are much more likely to develop atrial fibrillation. So you can see here that atrial fibrillation starts to be a problem for people typically in their 40s and 50s. By the time people are in their 70s or 80s, we are seeing a lot more atrial fibrillation. When patients are younger, we can have atrial fibrillation, it's just much more rare. So what are some of the other risk factors for atrial fibrillation in addition to age? Well, you can see here that things like genetics play certainly a role, and we know that there are things that run in families that are more likely to have people develop atrial fibrillation. So if you've had a family member that has had atrial fibrillation, you're more likely than not, compared to somebody who the family didn't have atrial fibrillation, to have AFib at some point in the future. Other heart disease can certainly lead to more atrial fibrillation. So things like having a prior heart attack or having high blood pressure or having problems with your heart's valves, those can be more likely to lead to atrial fibrillation. We know that sleep apnea is another risk factor for people having atrial fibrillation. Additionally, things like diabetes and other medical problems can also increase your risk for having atrial fibrillation. We talked a little bit about high blood pressure, which can definitely contribute. Obesity, we know, is a risk factor. For every 5 points higher in your body mass index, or BMI, you increase your risk of atrial fibrillation by 30%. Additionally, physical activity can be associated with atrial fibrillation, but that's typically for people that do very, very high levels of physical activity, like marathon running and things like that. We tend to think that people that do more moderate physical activity, walking, jogging, are at lower risk for atrial fibrillation overall. Finally, we know that alcohol also increases your risk of atrial fibrillation with an increased risk compared to non-drinkers. So going back to some of the genetics of atrial fibrillation. So is atrial fibrillation inherited? Well, it's a little bit of a complex question. We know that there is a genetic component, and some people that have genes that are more likely to cause atrial fibrillation are certainly going to be at higher risk of AFib. But genetics really aren't the only component related to that, and it's not a very well-defined entity. We think for genetics, it is probably a lot of different genes that have a small contribution to your risk for atrial fibrillation. And things like environment also play a role. However, we do again know that patients that have family members that developed atrial fibrillation at a young age are definitely more likely to have atrial fibrillation, and it's definitely worth thinking about if you've had a family member having some way of monitoring your pulse, or at least being a little bit more aware of your heart in terms of your risk for atrial fibrillation. What happens with AFib over time? Well, unfortunately, one of the things that we know is that atrial fibrillation causes more atrial fibrillation. So the more AFib that you're in, the more AFib you're likely to have. So we know that there are certain things that can contribute to AFib. We talked about aging, high blood pressure, obesity, diabetes, sleep apnea, alcohol, genetics. AFib tends to start for people with those risk factors as paroxysmal atrial fibrillation, where patients have triggers that lend to the initiation of AFib, but then termination of atrial fibrillation episodes over usually hours to days. Over time, as you get more of those episodes, the heart changes. And when the heart changes, you have buildup of scar tissue or fibrosis in the heart that can lead to more atrial fibrillation over time. That tends to lead to people being more what we call persistent atrial fibrillation, where the heart doesn't come out of atrial fibrillation on its own, and they need other means for getting the heart back to normal rhythm, such as either electrical or chemical cardioversion. Finally, some people will progress to what we call permanent atrial fibrillation, where no matter what we do, the heart will remain in atrial fibrillation and we can't get the heart to stay in normal rhythm over time. That's because there are changes that happen in the heart that lead to these things. So again, as we say, atrial fibrillation begets atrial fibrillation, where changes in the heart lead to the more likely maintaining more atrial fibrillation over time. What are some things that can happen to you as related to atrial fibrillation? Well, unfortunately, AFib increases your risk of stroke by a factor of about 5. That's because when the heart goes out of rhythm and the top chambers aren't beating normally, blood clots can form in those top chambers of the heart, and they can lead to a blood clot being sent to your brain to cause a stroke. We know that atrial fibrillation can also lead to congestive heart failure. When the heart is not pumping normally, when the heart rate is fast and not pumping normally, the heart is less efficient. When the heart is not efficient, it is not moving blood through it normally, and blood can back up, causing you to have shortness of breath, swelling in the legs, gain of weight, and other symptoms of heart failure. We also know, unfortunately, atrial fibrillation is linked to premature dementia. Things like Alzheimer's disease or vascular dementia are more likely when you have atrial fibrillation by a factor of 2. Additionally, for a lot of people, atrial fibrillation impacts their quality of life and unfortunately can increase your risk of death. One of the major things with atrial fibrillation is an impact on the quality of life. And we see a lot of patients that have symptoms with their atrial fibrillation, like palpitations, increased shortness of breath on exertion, just increased fatigue and decreased energy. So again, to speak to the effects on quality of life, a lot of patients that have atrial fibrillation develop palpitations, where people will feel their heart racing or skipping beats very frequently, can be very uncomfortable feeling while they're in atrial fibrillation. A lot of people that have atrial fibrillation also complain of shortness of breath, as well as fatigue, where they just can't do quite as much as they could do before, or they feel very limited in terms of their activity. Some people with atrial fibrillation develop chest pressure, discomfort when they're moving around. It can also lead to things like insomnia, anxiety, and depression. We know that in terms of these things, people feel 24% on average. If you poll people feel about 24% worse in terms of how they feel physically with their atrial fibrillation. They can feel about 23% worse in terms of how they feel socially functioning. They feel that they can't attend social events because they're anxious, or they just don't feel well enough to go to social events. In terms of mental health, on average, people feel about 16% worse. And in terms of their general health, people say they feel about 30% worse. How is atrial fibrillation detected, or how would you find out that you have atrial fibrillation? Well, some patients, again, feel their atrial fibrillation. They feel that their heart's out of rhythm. They feel that they're having palpitations. That can lead to them checking their pulse and going in for a doctor's visit to evaluate for atrial fibrillation. Some people check their pulse on a home blood pressure cuff. Sometimes this will tell you that your heart's out of rhythm, and patients can be alerted that way, where they can be then evaluated by a physician to see if they have atrial fibrillation. For diagnosis, the gold standard really is to use a 12-lead EKG or an ECG or electrocardiogram, which shows us definitively from an electrical standpoint if the heart is in atrial fibrillation. There are other tools that some patients have now to be able to self-diagnose atrial fibrillation. You may have seen some of these things. So one of them is a smartwatch-enabled device or smartphone-enabled device that will provide an EKG for patients. And that EKG can be read by the device as being either normal or likely to be atrial fibrillation. That can be shared with a physician who can then read that EKG to say, yes, this looks like atrial fibrillation, or we need to do more testing. There are a number of different smart watches that you may be aware of, like the Apple Watch or other device watches that can then detect heart rates and tell you if your heart rate is irregular. Those can be quite helpful looking for atrial fibrillation or for a normal rhythm as well. And some of these watches or other devices can give a list of these EKG episodes that you can then bring to your physician, who can look at them and tell you if you are truly having atrial fibrillation or not. These are some of just examples of what that would look like. Here's an example of normal sinus rhythm, and you can see that it's pretty regular here. So this suggests that the patient is not in atrial fibrillation, which can be reassuring to patients when you're worried about things like this. We do have other new technologies as well that we often prescribe for patients if we're worried that they may have atrial fibrillation. And these include wearable patch monitors that allow us to have ongoing EKGs for many days to evaluate the heart to see if atrial fibrillation happens. Additionally, there are implantable monitors that we sometimes use that can be implanted underneath the skin to allow us to evaluate these for longer periods of time. So whereas a monitor may only be able to evaluate the heart for several days to weeks, an implantable monitor can monitor the heart for up to several years. So one question that frequently comes up for patients is, what can I do to reduce the risk of developing atrial fibrillation or reduce episodes of atrial fibrillation? Well, this gets into talking about various different ways that we can help prevent atrial fibrillation and ways that we can treat atrial fibrillation. One of the first things that we talk about is helping manage your risk factors for atrial fibrillation. So as we talked about before, there are a number of different risk factors for atrial fibrillation. Some of these are modifiable, some of them are not. So unfortunately, age is not modifiable. We can't prevent you from getting older. Genetics is another thing that's not modifiable. You're born with the genes that you're born with. Other heart disease can be a modifiable risk factor, but again, a lot of that is making sure that you're treating other heart disease. Now we're starting to talk about things that can be modified, such as sleep apnea. And we do know that if we modify patients' sleep apnea by treating that with therapy for sleep apnea, that it can help reduce the risk of atrial fibrillation. We know that helping treat diabetes so that diabetes is better controlled will reduce your risk of atrial fibrillation. High blood pressure, similarly, if we reduce high blood pressure by either treating it with medicine or weight loss or other lifestyle changes, can help reduce your risk of atrial fibrillation. Similarly with obesity, similarly with physical activity. As I said before, patients that are not physically active at all are at higher risk for atrial fibrillation. Patients that are extremely active, running marathons or doing other very, very high endurance sports are at some risk, but finding a moderate ground there tends to reduce the risk of atrial fibrillation over time. And then we know that alcohol use increases your risk, so limiting alcohol use or abstaining from alcohol can reduce your risk of atrial fibrillation as well. As we talked about, this is sort of a list of various things that we can talk to people about in terms of their risk factor reductions. So weight management and exercise is a pillar of reducing your risk for atrial fibrillation. Reducing your weight and increasing your physical activity to being active to 3 to 5 days a week can be very helpful for reducing atrial fibrillation. We know that treating high blood pressure and high cholesterol levels are important. Treating sleep apnea is important, and treating diabetes is important. Looking at all these things, when we're able to achieve these things, it can really reduce your risk of atrial fibrillation. So if you look at this top group here, these were patients that had risk factor management, and they reduced their risk of atrial fibrillation by about by having 80% freedom from atrial fibrillation. If you don't do those things, patients they continue to have atrial fibrillation, and their risk is quite a bit higher. What about weight reduction? Does that matter? Well, if you look here, for patients that lose about 10% of their weight, their risk for atrial fibrillation is 90% over several years. For patients that lose 3 to 9% of their weight, they have a risk of 70% of atrial fibrillation. And for people that don't lose significant amounts of weight, less than 3%, or they gain weight, their risk for developing atrial fibrillation again is about 40%. So we know this is a major factor in trying to help reduce your risk of having atrial fibrillation in the long run. What about exercise? Well, again, we talked about doing moderate intensity activity for 3 to 5 times a week. And by doing this, we know that this can help reduce your risk of atrial fibrillation. As I discussed, endurance exercise where people are doing high amounts of activity for several hours a day can increase your risk of atrial fibrillation. But again, moderate activity does decrease that risk. And other things like low activity, things like yoga and things like that can also reduce your atrial fibrillation, can reduce your blood pressure and help make people more agile and just feel better in terms of their quality of life. What about alcohol? Well, again, we know that alcohol is related to atrial fibrillation risk. And really, it starts, unfortunately, at one drink. And so any drinking we think is related to an increased risk of atrial fibrillation. And so there on the top graph there on the blue line, every drink that you have per week increases your risk of atrial fibrillation by a small amount. We do know that there may be some cardiovascular risk reduction, so your risk of heart attack may be slightly lower with alcohol, but that does not seem to be true for atrial fibrillation. Again, we know that there's a very close link between lifestyle and atrial fibrillation, and about half of the risk for developing atrial fibrillation is related to lifestyle risk factors, things like obesity, high blood pressure, diabetes, and exercise, which are all things that you can control to some degree. We can make all of those things better if you focus on management of those things. Again, as I discussed, there are some things that are not modifiable, like your age and genetics, but there is a lot that you can do yourself to reduce your risk of AFib. Let's talk about one of the major risk factors with atrial fibrillation, one of the major bad complications, which is stroke. So one of the major pillars of atrial fibrillation is making sure that we reduce the risk of stroke, either through anticoagulation or other methods. So first of all, what's the link between AFib and stroke? Well, AFib is the most common contributor of stroke in patients. Often stroke can be the only symptom of AFib. So I know about symptoms that patients with AFib have before, but as you'll hear from some patients, as we hear often from patients that we see, and you'll hear from some of the patient testimonials today, some patients really have no or very minimal symptoms with their AFib, and they can present with just a stroke. Typically, unfortunately, strokes caused by AFib can be very severe. And we know that the risk of stroke for patients that have atrial fibrillation increases as patients get older, as they have higher blood pressure, as they have diabetes, heart failure, or other heart disease or prior strokes. When we look at patients that have atrial fibrillation, we're often weighing what are the risks and the benefits of using blood thinner medicine to prevent stroke. And we look at not only do they have atrial fibrillation, but what are their other risk factors as I just described. We use scoring systems like this to help determine how high the risk is and how we can talk to patients about what that risk is and in terms of what their risk for bleeding on the blood thinner is and their risk for stroke, to try to find that balance where we think the benefit of a blood thinner outweighs the risk of the bleeding risk. So once we've determined that risk, what are the ways that we can help treat the risk for stroke? As I talked about, there are a couple of different ways. So the most common way that we do this is we use medical therapy called anticoagulation therapy. And you'll recognize potentially some of these things like warfarin, dabigatran, rivaroxaban, apixaban, and edoxaban are all medicines that we can use that are called blood thinners to reduce your risk of stroke. They are very effective at reducing the risk of stroke. There are also other things that we've developed over many years of research, which are devices that can be implanted in the heart to also help reduce the risk of stroke. There are also things that can be done surgically to reduce the risk of stroke. One thing that we often get asked about is, what about aspirin? Doesn't that thin my blood enough to reduce the risk of stroke? Over many years of research, it turns out that aspirin is not very good at reducing the risk for stroke with atrial fibrillation. It is effective for heart attacks and other things like that, so your doctor may prescribe aspirin for other reasons. But for stroke prevention for atrial fibrillation, most electrophysiologists and other doctors now think that aspirin does not have a major role in terms of reducing your risk for stroke. So how effective are blood thinners at reducing the risk for stroke? They're extremely effective. They reduce your risk for stroke by about 70 to 80%. They work quite well, and their risks now are quite low. So in terms of anticoagulation, the oldest drug that we have that's been around for more than 60 years is a drug called warfarin or Coumadin. And that's a medicine that works quite well to thin the blood, but it does require blood monitoring so that we can make sure that the levels are right. If the patient has too high of a level of warfarin in their blood, their blood can be too thin. If the level's too low, their blood can be too thick, and they can be at risk for stroke. There are a number of newer blood anticoagulants that we are going to talk about here in just a second. So the newer anticoagulants are very good at preventing stroke. They're just as good at warfarin, as good as warfarin, and we think that they have a lower risk of causing bleeding issues. They tend to cause less bleeding than warfarin. They don't require blood testing, and they have few interactions with other drugs, whereas warfarin does have some interactions with other drugs. One worry that some patients have about some of these newer drugs is that they may not be as easily reversible as warfarin, but in the last several years, there are a number of different agents that we can use to reverse your risk of bleeding with these agents as well. Unfortunately, there are some limitations to using these medicines, so patients that have mechanical heart valves or very significant heart valve disease, we cannot use these newer medicines in, and they do need to use warfarin. Unfortunately, one of the risks of blood thinners is that there are always risks of bleeding on them. And so just to be aware of that. But again, when we're choosing these medicines, our goal with you as doctors and patients is to decide between the two of us what the risks and the benefits of these things are, and to figure out what the safest thing for you as an individual patient to do is. So again, one thing that has been developed, we talked about, is our devices that can go inside the heart to help reduce the risk of stroke. There's a small area in the heart in the left atrium called the left atrial appendage, and this is the area where most blood clots in atrial fibrillation develop. We know that if we block that area off, that it can help reduce the risk of stroke. Again, it doesn't make it perfect, but it definitely reduces the risk. And one way that we can do this is we can either close that chamber from inside the heart by putting in this device like this Watchman device. We also know that it can be occluded from the outside by putting on external devices or doing surgery. We know that over many years of research that it does appear that these devices, the Watchman in particular, seems similar to blood thinners in terms of stroke prevention. Now that we've talked about treating the risk for stroke, let's talk about how we treat atrial fibrillation itself. As we talked about before, the risk for stroke and treating stroke risk doesn't really help with the quality of life issues related to atrial fibrillation. And again, going into how we help reduce your risk for atrial fibrillation and improve your quality of life is what I'd like to talk about now. So there are two major ways that we treat atrial fibrillation. One way is to try to control the heart rate. One major problem with AFib is that when people go into it, they are quite fast. And when the heart is very fast, it makes the heart very inefficient, and it makes people not feel very good. You can imagine kind of running a marathon all day long with your heart. Your heart tires out and you're just not very efficient. So often for patients, what we do is we try to just reduce the heart rate. And by doing that, often patients feel a lot better when their heart rate is lower in atrial fibrillation. But sometimes that doesn't solve all the patient's problems in terms of how they feel. And one thing that we try to do also is we can try to not only get the heart rate slower, but we can actually try to restore and maintain normal rhythm by doing something called rhythm control. We know that doing rhythm control, either by using medical therapy or doing a procedure called an ablation, tends to actually improve patients' care. So more recently, trials have demonstrated that there is an improvement in terms of how people feel and in terms of reducing the risk for stroke, death, and hospitalizations when we reduce when we try to control their heart and keep it in normal rhythm. We do try to maintain normal sinus rhythm for patients that are typically symptomatic because it does help reduce symptoms, but it also may reduce the risk of these other things as I described. We also think for some patients, maintaining normal rhythm may help improve your longevity in terms of your life. That's not true for everyone, and again, it's an individual discussion with your physician. One way that we often try to get people back to normal rhythm is we try to use medical therapy, which are drugs, such as these drugs that I've listed here, flecainide, propafenone, sotalol, dofetilide, dronedarone, or amiodarone. Those can help maintain normal rhythm, but it often requires us to get the patient back into normal rhythm to begin with, where we use a cardioversion or we use electrical energy to get the patient back to normal rhythm, and then the medicines are used to help keep people in normal rhythm. So what are typical ways that we think about triaging patients in terms of their different types of atrial fibrillation and what we might offer? Well, for patients that have paroxysmal atrial fibrillation, the episodes are very infrequent. Sometimes we don't do much. We just say, let's watch and see what happens, or we say, why don't we try a pill in the pocket where you can take a medicine as needed for atrial fibrillation, or we can do a cardioversion as needed for atrial fibrillation. As patients start to have more frequent episodes of atrial fibrillation, they start happening once a month or a couple of times a week, we start talking about doing other things like using drug therapy to try to prevent episodes of atrial fibrillation. Or we also talk about, if that fails or patients are not feeling well on those medicines, about going to do what we call atrial fibrillation ablation, which I'll describe in a minute. As patients develop more persistent atrial fibrillation, we talk about, if patients are very symptomatic, going to antiarrhythmic therapy with drug therapy. And again, if that doesn't work, we then go to atrial fibrillation ablation. If patients are asymptomatic with persistent atrial fibrillation, sometimes we use what we call the rate control method, where we leave patients in atrial fibrillation and just try to control the heart rate to see if that makes them feel better. But again, if none of this is making patients feel better, we really like to try to get them to atrial fibrillation ablation if drugs or other medical therapy is not working. Finally, some people develop permanent atrial fibrillation, and that's where patients have been in atrial fibrillation for so long, often medical therapy or ablation is not going to work well for that patient, and some patients remain in atrial fibrillation. So typically at that time we say, let's stop antiarrhythmic therapy or stop those medicines for atrial fibrillation, and we'll just try to control the heart rate. And if we can't do that well, sometimes we end up using a pacemaker and trying to make the heart rate very slow by doing a different type of ablation, and then a pacemaker helps keep the heart rate from being too slow in those situations. Let's talk a little bit about atrial fibrillation ablation and what does that entail? Well, what is an ablation? It's a medical procedure where we try to fix the heart's faulty electrical activity by destroying the tissue that's causing the atrial fibrillation. So as I talked about before, there are those areas of triggers that cause your heart to go into atrial fibrillation. And as electrophysiologists, we know where those areas are, and we can use either heat or cold or other types of energy to try to isolate those areas electrically. The procedure typically is a minimally invasive procedure where we access the veins in the groin and we go inside the heart with our catheter, find those areas, and do the ablation. The ablation can take between 3 and 4 hours. The outcomes of the procedure differ depending on the patient, and underlying conditions as well as the type and duration of atrial fibrillation that you've had can help determine how much success you might anticipate with atrial fibrillation ablation. This is something to discuss with your doctor. There are obviously, when we do procedures, risks to those procedures. And so the risks for these procedures tend to range from about 1 to 3%. And again, that's something that your doctor can discuss with you more in detail when you discuss these procedures with your doctor. So what are the benefits of ablation versus using drugs? We know that ablation works slightly better than drug therapy works, where patients that get rhythm control therapy with an ablation do tend to have better outcomes than patients that are just on drugs. But again, some patients choose drugs because they believe that they're concerned about some of the side effects of the ablation or some of the risks that are associated with it. One question that comes up is, when we do ablation, is there any difference between using the different types of energy for ablation? And as I discussed, we can use either heat energy or freezing energy. Well, for heat ablation, this is a graphic showing that. So for radiofrequency heat ablation, what we typically do is we place a catheter inside the heart where we can apply small amounts of heat to different areas around the pulmonary veins, which are where the triggers from atrial fibrillation come from. By doing that, we can create isolation of those veins. With cold energy, called cryoballoon or cryofreeze, we use a balloon-shaped catheter to apply a circular lesion around the pulmonary veins. This works quite well as well. One question that we frequently get is, can a pacemaker fix my atrial fibrillation? What I tell patients about this is that pacemakers are very good at treating slow heart rhythms, but they are not good at treating fast heart rhythms. So unfortunately, atrial fibrillation tends to be a very fast heart rhythm. And a pacemaker can't slow the heart down. It can only keep it at a rate or speed it up. So it can't keep it lower than the heart rate wants to go. Since atrial fibrillation tends to be fast, pacemakers don't tend to work very much in atrial fibrillation, but they do help us in certain situations. So sometimes when patients have atrial fibrillation and we need to treat them with drug therapy to try to keep them in normal rhythm or try to keep the heart rate slow enough so that they're feeling okay, using a pacemaker helps prevent the heart rate from being too slow. One other thing that we sometimes do is we can knock out the wiring system in the heart to prevent the conduction of electricity from the top part of the heart to the bottom part of the heart, and then the pacemaker helps prevent the bottom part from being too slow. So those are sort of the two ways that we use pacemakers in atrial fibrillation. So as we talked about, this is what's called an ablate and pace strategy, where we knock out the wiring system in the heart. The top part of the heart would then stay in atrial fibrillation. The heart is going fast in the top chamber, which you don't feel. What you feel is the bottom part of the heart beating, which needs to then be controlled by the pacemaker. Otherwise, it would be too slow. When we do this, we have not really cured the atrial fibrillation, but we've allowed the heart rate to be controlled entirely by the pacemaker, so the heart rate is no longer fast. In this situation, patients do need to stay on blood thinners because they are still at risk for stroke from atrial fibrillation. As I talked about, this is where we knock out the wiring system. There's no electricity going to the bottom part of the heart, and the pacing is done by the pacemaker. So we've talked about a lot of different things, but as you can imagine, this therapy is very complex and needs to be individualized to the patient. So not everybody's the same. Not every patient has the same desires for their treatment. Some people are very happy to be on medical therapy. Some patients would much rather be off of medical therapy and have a procedure. It's very important to discuss all these various things with your physician so that they know what your preferences are and they can describe to you what the benefits and the risks are of these different approaches. So what are ways that you can help prevent atrial fibrillation and live a better life? Well, we have these different mnemonics, but again, one way to think about this is just to go back to trying to control some of the risk factors that you can control. And again, trying to have abstinence from alcohol and tobacco products, controlling blood pressure, trying to treat sleep apnea, treating diabetes with a good goal, exercising with moderate aerobic activity, looking to do weight loss, having a healthy diet, and having a good body mass index are all things that can help reduce your risk of atrial fibrillation. Our job as physicians is, again, trying to help you manage and treat your atrial fibrillation as a team approach. This is something where you're going to be meeting with your cardiologist, having discussions with them about the best treatment options, and managing this over time. And our job is to try to provide you the best therapies that we can provide you and the best options. Finally, I want to just give a plug to our atrial fibrillation prevention clinic, which is here at St. Luke's. We've got great ways of doing this where they can help manage lifestyle things like weight, high blood pressure, diabetes, and other things. It's a great service that we have in addition to all of the advanced treatments that we have for atrial fibrillation here at St. Luke's Hospital. And again, this is the brochure, but this talks about all the various things that you can do to help reduce your risk of atrial fibrillation, some of the things that are related with AFib over time. And with that, I really want to thank you for your attention today. We really appreciate your coming. I hope this has been informative for you and your families. If you have questions that, again, come up, please put them in the chat box. We're happy to answer them. What I'd like to do now is introduce a couple of patients who've had atrial fibrillation so that they can talk about their experience with their atrial fibrillation and their treatment with you. Their names are Marty and Mark. So Marty, thank you so much for joining us today. I'm Dr. Steinhaus, and it's really nice to meet you. We haven't met before, but it was nice to talk to you a little bit beforehand. Today what we're trying to find out from you is just get a little bit of information about your atrial fibrillation so that we can share that with other patients and let them know what your experience has been with what you've had. And I wanted to start by asking you, how did you find out that you had AFib, and what was that like?
Well, it was really interesting. I was going in for cataract surgery at outpatient at Lee Summit Hospital. And as they were deadening my eyes, the anesthesiologist said, "Do you have any heart issues?" And I said, "Well, I've had a heart murmur for years." And he said, "Let me just check that." And the minute he checked it, I could see his eyes above his mask. And he said, "Call and see if there is an open room in the emergency room." And so they did, and my heart rate was 200.
Wow.
And so they, of course, over the course of about 4 or 5 hours, was able to break it down. And then that led me into finding Dr. Gupta.
Got it. And tell us then, sort of after that, what happened next? Good.
And I did quite a bit of research. Dr. Gupta came highly recommended to us. And so I set an appointment and we began the process. When I went in, of course, I did an EKG and I was in AFib at that time.
Uh-huh. Got it. And with your AFib, could you feel it going on a lot of the time or not so much?
Oh, and that's what I found so odd,
Yeah.
that I didn't really have any symptoms basically other than that one sharp pain
Uh-huh.
that I thought was unusual. I never had that before, but
Yeah.
no symptoms.
Yeah. Some people notice that they get a little bit more short of breath when they're doing activities when they're having AFib. Is that something that you noticed at all?
I really didn't notice that. Now, that might be because I'm not quite as active as I should be. So I didn't really notice a shortness of breath. I did notice kind of lower energy.
Uh-huh.
The energy wasn't quite what I expected it to be.
Yeah. That's another relatively common symptom that we hear from people. Not always related to AFib, but we can definitely see that happen. So tell us, so you saw Dr. Gupta, and it sounds like you both talked. Tell us about what that conversation was like. What did you talk about?
Well, Dr. Gupta basically went through a lot of the history of my family and, the fact that my mother had had heart disease. And we started discussing, he said, gave me a lot of information. He said, "Now, I know I'm giving you a lot of information, but we're going to take this a step at a time," which I so much appreciated. I mean, we did testing to make sure that everything was correct, that it wasn't another heart issue.
Mm-hmm.
And so I was so grateful that he was cautious as we went through and very clear. And the same thing with his staff. They were always available to answer any questions I had because once I left, of course, it's like, oh my gosh, I've got a million questions.
Mm-hmm.
So it was really, I was thankful that I went through all the testing because I found out through all that testing that my heart is really good.
Yeah. 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 And that's a common thing that we find too, that AFib can be a problem just by itself. And but it's good to do all that testing for sure.
Yes.
Tell us, it sounded like you chose to do an ablation procedure with Dr. Gupta. Tell us about how you decided to do that and what that was like.
Basically, it was Dr. Gupta's recommendation. I said, fine, if that's what you think I should have done. I was extremely nervous about this because anytime you think about going into your heart or doing anything with your heart, I was amazed though when I started talking to friends about how many people they knew had had this surgery
Mm-hmm.
and had done extremely well.
Mm-hmm.
And so I felt better about it, but he explained everything in detail, exactly the process, what would happen, how they go up through my groin and into the heart. I probably spent a night in the hospital and, so I felt comfortable because I really felt like I knew what was going to happen to me.
In terms of the recovery from the procedure, how did that go and what was that like?
Well, I came home and of course I just took it easy. I was on a couple of
Mhm.
medications and they told me as the process continued of the healing of what had been done, that I might find myself go into AFib or think I'm in AFib again. And that did happen to me. It was on a weekend. I called in. I said, I think I'm having skipping a beat. Well, what I had purchased, or my husband had purchased for me, was one of those watches that you could actually take your heart rate and all
Hmm.
that.
Hmm.
And when I took it, I was not in AFib,
Hmm.
but I felt like I was.
Hmm.
I was more aware of my heart, I guess I
Hmm.
would say I had been before.
Yeah,
But I was not in AFib. But they said it's not uncommon when you're healing for that to happen, but
that's right.
very occasionally. So, it turned out that I was just fine. So,
Yeah, good. Well, I'm glad to hear that went well. Tell us, what would you say overall, what's your experience been like with AFib and, what have you learned?
well, what I've learned is when you have any kind of a symptom that is not normal, that isn't your everyday way of living, that you really do need to go check it out.
Hmm.
For me, those occasional fast pulse skipping of the heart, I attributed that to what my mom went through. I said, oh, well, she went through it. It's no big deal. And I had to wait till the fact that I was really in danger when my heart rate went so high for me to realize that pay attention to anything in your body and at least get it checked out.
Hmm.
That is the most important suggestion I can make to people. So I felt, very blessed that I was able to go through this and have a great experience and not having any problems. I'm now off Eliquis. I went through after the ablation. I went through a heart monitoring after several months,
Hmm.
and for 2 weeks, I carried that little heart monitor around with me, and so it showed no AFib at all. So now I'm off
Great,
Eliquis. I'm off any medication.
great, great. How would you compare your health now to how it was when you were diagnosed with the AFib?
Oh gosh, it's better. It's so much better because I do have more energy. I feel uh, that that's not going to happen to me again. I'm not going to have the skipping of the heart. It's
Hmm.
just like I feel kind of renewed.
Hmm.
That makes sense. I just feel like just more confident and more comfortable that I don't have to worry about what that is going on with me.
Got it. That's
So,
great. Good. That's good to hear. Tell us, is there anything else that you would tell other people that have AFib or are wondering about AFib? Is there any other advice that you might give other people?
well, I would say, as I mentioned, just don't let that go on. uh, Take the time to make an appointment, to go in, to have some testing done. You don't want to wait to the point where something more serious could happen, because I understand that if you don't get this corrected, you could have a stroke.
Yeah.
With the blood accumulating in the lower part of my heart, that could have caused blood clots, and I could have had a stroke. So, my main message to everybody I talk to that has any type of heart issues is check it out.
Hmm. You did great. Thank you. Thank you again so much. We really appreciate your time. Mark, thanks so much for being with us today. We really appreciate your time, and I think hopefully other patients will really appreciate just hearing about your experience. So, with that said, tell us a little bit about how you first found out about your AFib.
Well, it was back, I would say it'd been happening. I've been gaining weight and just losing stamina. And I understood I was getting overweight and I was getting older, but from one morning it was actually Halloween night last year that it all came to fruition. my grandchildren were out trick-or-treating and having fun in the front yard. And I was at a point in my life, I was so tired and overweight and with the AFib that I can honestly tell you, well, I'm 58 years old and I cried like a 2-year-old kid because I felt that bad.
Mm.
And I woke up that next morning and I just said that something's got to give here because I don't want that. This isn't my life. I'm not enjoying my grandchildren. I'm not enjoying my children because not of them, but because of me being physically just wore out and exhausted. I mean,
Yeah.
people don't understand. People say they're tired, but this is beyond, I'm tired from a day's work. This is total, I don't know. I mean, I don't know how to put it. You're just exhausted. Everything is an effort. It's an effort to get out of bed. It's an effort to walk. Everything's an effort.
Yeah. Yeah. And that's a common symptom that we hear from people. Tell us, did you have other symptoms too, like palpitations, feeling skipped heartbeats or heart racing, things like that? Could you feel that?
Absolutely, all of that.
Yeah.
It all was the typical signs of AFib,
Yeah.
but I didn't know what it was.
Yeah, sure. So tell us then, how did you end up getting diagnosed? Did you come in and see a doctor? How'd that work out?
I went to see Dr. Melissa Smith, my family doctor, and I walked in. I went to work that morning, and literally I had maybe 50 yards from my car to my plant door, and I had to stop halfway to catch my breath.
Yeah.
And I got into the plant and got things going and called my wife at 8:00 and said, I need a doctor's appointment. And went and seen my family doctor and went and seen her. And she told me to go to the emergency room. I'm sure she knew what was going on, but she didn't say anything. This was during the COVID crisis. So I went to St. Luke's East and there was maybe 200 people in this waiting room at ICE in emergency. And I went back and the lady put me on the EKG and she goes, oh, something's wrong with this. It's not reading right.
Mm-hmm.
Well, it was. She just didn't know what was going on. Well, I knew that they do triage and stuff like that. Well, with 200 people there and you barely come out of the triage room and sit down and they go, call your name. You just went to the head of the line. That's not good. You're like, oh no. She goes, yeah, you're in AFib.
Huh.
Basically, that's how it was. Like I said, it was just, I was tired, and not just tired, but physically drained and emotionally drained from the fight. It had been a fight so long that it was everything every day. And being a man, but this is things that were completely different than that.
Yeah, yeah. So tell us a little bit about, so what happened next in everything?
I went into the hospital and they diagnosed me with AFib.
Uh-huh.
Met with some of the cardiologists there at St. Luke's, and they tried, I can't remember, they tried to shock my heart back into
Mm-hmm.
rhythm. And it worked for about 12 hours. And then I went right back into AFib.
Mm-hmm.
And then they put me on medicine. I was in the hospital a week during this time. And, basically my wife could come in and see me, my lovely wife of 35 years, could come in and see me for maybe an hour a day because she has stage 4 breast cancer.
Oh, wow.
And I didn't want her out in the COVID stuff that's going on either.
Yeah.
So it gave me a lot of time as a man to sit there by myself and go, how did you let yourself get to this point? How did you get to this point when you have a wife that's stage 4 breast cancer? How did you let yourself get to this point that you're not going to be there for her?
Hmm.
And that's just when I made the decision that things were going to change. It was just, I had to change my life for her, not only for my well-being, but to be there for her and my grandchildren.
Yeah. Well, it sounds like you ended up then meeting with Dr. Gupta and talking about atrial fibrillation and thinking about ablation and things like that. How did you kind of make that decision when you were talking with him?
They had put me on, I don't know the name of the medicine, but it was the strongest heart medicine that they had.
Mm-hmm.
And it wasn't helping. I mean, there was just, it wasn't helping. That's how bad my AFib was. And of course, they tried shocking me and it didn't work. So that's when Dr. Gupta told me, you know, hey, we need to think about ablation.
Yeah.
And I said, well, let's just do it. I mean, if this is what I need to do to get to where I want to be, then I'm fine with it. And, you know, the procedure was great.
Yeah. Yeah. Tell us a little bit about how did it go? How did the procedure go? What was your experience with that?
I got up in the morning, went to St. Luke's on the Plaza. They got me prepped for surgery. I went in, they done the surgery, no complications. I've been enough around my wife and her surgeries that she's had. I know you got to get right up out of bed or they don't let you out of the hospital real quick, right? So, I mean, literally, I got back to my room and I said, give me my clothes. I want to get up and walk around.
Yeah.
So I was literally up 30 minutes out of surgery, walking around. I mean, there was no soreness, nothing.
Good.
Nothing like that. Yeah, I mean, I was up moving.
Good.
So
good. That's great. I'm glad to hear that. Tell us, you know, after the procedure, how did you feel? Tell us about how that went right afterwards.
At first, I would say probably the first week, I really didn't notice a lot.
Mm-hmm.
And then after that, you could tell leaps and bounds. I mean, I could start walking again.
Mm-hmm.
I started like losing weight, and you know, other things that I have done. But yeah, I mean, and then within the next 3 weeks, it was 180.
It sounds like you've done really well. And it also sounds like you've done some other things to try to help yourself stay in normal rhythm.
I mean, if I could tell anybody anything, it's the doctors can't do it all. They have to have help, and you have to be the one to help yourself. And I mean, I quit drinking. I don't drink anymore. It's been a year and I haven't had anything to drink. I've lost a little over 100 pounds.
Wow.
Still got a few more to go. So it's a team effort. The doctors can't do it all and you can't do it all. We need to come together, and you need to understand that this is a 2-part process. It's his process and yours.
Yeah.
To help you. And now the only time I get a heart murmur or anything like that is I can tell if I drink too much caffeine. That's it. Other than that, I sleep all night long and I don't have any issues with the heart murmurs anymore.
Good. I'm glad to hear that things are going really well for you. Tell us, you know, how would you compare your health now compared to how you were before the AFib ablation?
If I was a 1 before the ablation, I'm a 9.5 now.
Great.
Really, I mean, I have a long way to go, but I mean, it's wonderful.
Good. I'm glad to hear that. Tell us, you know, if you had anything else you wanted to say to anybody that has AFib or is worried about AFib or things like that, what kind of advice would you give people?
Well, the first thing I would want to tell them is be worried about AFib. It's not a joke. It will kill you. And, the other thing is like I said, when I had that time to sit and think, you're being very selfish if you're not thinking about the people around you. I mean, your wife, your grandchildren, there's somebody out there that needs you, that needs you to have them there. And you need to look outside yourself and go, what is the best for me to be the best for them? And I want to be the best person I can for them.
Yeah.
Because they need me here. Be it your grandchild, be it your wife, your husband, your significant other. I don't care. Somebody needs you there. And you have to take this very seriously and help yourself. Please help yourself.
Yeah.
I mean, I couldn't beg you more. My life has changed so much from going to, I mean, I'm going to spill my guts here because I want to help somebody. From coming home from a job that I was on my feet in a factory for 9 hours a day, drinking a 6-pack to self-medicate because I hurt so bad. So I could go to sleep, to wake up, to hurt so bad, to come home to do the same thing over again. and it's not a good cycle to get in. It's
Yeah.
not.
Yeah.
I've been there. I've done that. I admit to that. My life now, I mean, it's completely different.
Oh,
Completely different.
yeah. I want to take the opportunity to thank you all again for coming and watching this video presentation. We really hope that you enjoyed it and that you learned something today. I'd like to also, again, encourage you to send in any questions that you have. We'll answer those in an email that comes out after this video has been posted. Finally, we'd like to share with you a video of our EP lab so that you can enjoy a tour of that and see what it would be like if you came in to have an ablation here at St. Luke's. Thanks again. We hope you have a wonderful day.
St. Luke's Mid-America Heart Institute offers the most comprehensive heart and vascular care in Kansas City, providing the full range of cardiovascular treatments and services. With more specialized physicians, experience, and innovative treatment options, St. Luke's is a pioneer in cardiovascular care and heart rhythm disorders. Atrial fibrillation, or AFib, is a common type of heart arrhythmia. It causes fast, chaotic electrical signals in the atria, leading to abnormal functioning of the heart. It also affects how much blood your heart can pump out to the body. Not that long ago, many heart conditions required open heart surgery. Today, the Heart Institute's expert physicians treat arrhythmias and other heart conditions with less invasive procedures. AFib can be treated with catheter ablation, a minimally invasive procedure performed by St. Luke's cardiac electrophysiologist or heart rhythm specialist. The compassionate care at St. Luke's begins the moment you arrive. Enter St. Luke's Hospital through the St. Luke's Marion Block Neuroscience Institute parking garage. Here, a screener will take your temperature and direct you to admitting. Shortly after check-in, you will be taken to a preoperative area where your care team will prepare you for the procedure. You will also have a chance to talk with your electrophysiologist. When the team is ready, they will transport you to the procedure area. St. Luke's highly trained cardiovascular team performs catheter ablation in a state-of-the-art electrophysiology or EP lab. Your safety and well-being are their top priority. The sophisticated equipment in the EP lab provides your heart team with the data and information it needs to perform the procedure.
During a catheter ablation procedure, a thin, flexible tube, or catheter, is placed through a small incision in the leg, where it's then advanced up through a vein and into the heart. There are two phases during a radiofrequency ablation: mapping and ablation. During mapping, an electrophysiologist creates a three-dimensional image of the heart using specialized catheters in order to identify the area of abnormal electrical signals which may be causing the arrhythmia. In the second phase, ablation, the electrophysiologist directs a catheter to the targeted areas and delivers radiofrequency energy in order to create a small scar within the heart muscle. This will then block the faulty electrical impulses and restore normal electrical pathways in the heart.
Catheter ablations are outpatient procedures and usually take 2 to 3 hours to complete. After your procedure, the electrophysiologist will meet with you and your loved ones to share results and discuss next steps. Before being discharged, an advanced practice provider will provide specific at-home instructions, schedule a follow-up appointment, and answer any questions you have. We hope the information in this video is helpful as you and your loved ones consider treatment options and prepare for this procedure. As one of the top cardiovascular programs in the country, you can be confident that your heart is in expert hands at St. Luke's.